So we are live now. Good afternoon, everyone. Myself, Bruna Shaha from ExRxIndia and Research West Bengal, welcoming you all in this webinar series for the students, by the students, and I am thanking our founder and everyone related to us. And I would like to have a quick start for this session as we are running late actually. This session will be presented by by Jyoti. And I would like to request Jyoti to start it, please. Share your screen and start speaking. Jyoti, you can share your screen.
Yes, ma'am, I'm sharing.
Yeah. Please go to the presentation. Yeah, and start speaking.
Good afternoon, everyone. Myself, Jyoti Aggarwal, a BPT first-year student from Delhi Pharmaceutical Sciences and Research University. First, I would like to thank Chandramohan sir, Rupesh sir, and Duna ma'am for giving such a wonderful opportunity to me. Now, I would like to start with my session, that is Anatomy of Medulla Oblongata. So, medulla is the lowermost part of brainstem extending from foramen magnum to lower border of pons. It is shaped like a bulb and it measures about 3 centimeter in length, 2 centimeter in breadth, and 1.25 centimeter in thickness. It has vital center, and these are cardiac center, vasomotor center, and respiratory center that control the heart rate, blood pressure, and respiratory rate respectively. It provides attachment to last 4 cranial nerves, and the dorsal aspect of medulla is divided into lower closed part and an upper open part. Now we'll see the external features on the ventral aspect. So here we have anterior median fissure in the midline, and posteriorly we have posterior median sulcus. So they both divide the medulla into 2 symmetrical halves. Lateral to this, we have anterior lateral sulcus and posterior lateral sulcus that divide the medulla into anterior, lateral, and posterior surface. So anterior median fissure end above as a triangular depression called foramen cecum, while below it is interrupted by pyramidal decussation. In between the anterior median fissure and anterior lateral sulcus, we have longitudinal elevation called pyramids, and they receive the corticospinal tracts from the cerebral cortex. Lateral to this, we have oval-shaped elevation called olives. Olives have inferior olivary nucleus beneath them. Rootlets of hypoglossal nerve arise from the anterior lateral sulcus, while the rootlets of 9th, 10th, and 11th cranial nerve arise from the posterior lateral sulcus. Now we'll see the dorsal aspect. So the central canal from the spinal cord ascend above till to the lower half of the medulla. From here, its lip diverge and they form the boundaries of lower or fourth ventricle. So in the closed, so we have open part, upper and lower closed part. So in the midline, we have posterior median sulcus. From medial to lateral, we have 3 longitudinal elevation, and these are fasciculus gracilis, fasciculus cuneatus, and inferior cerebellar peduncle. Fasciculus gracilis and cuneatus expand above to form gracile tubercle and cuneate tubercle having nucleus gracilis and nucleus cuneatus. Lateral to cuneate tubercle, we have tuber cinerarium, and it has spinal nucleus of trigeminal nerve. In the open part, we have hypoglossal triangle, vagal triangle, and the vestibular area. So this was about the posterior aspect. Now we'll move to the internal structure, which we will going to study at 3 different levels. So first we'll study at the level of pyramidal decussation. So in center, we have gray matter, while in periphery, we have white matter. The posterior aspect of central gray matter elevate, and it modified to form nucleus gracilis and nucleus cuneatus, while the posterior horn expand to form spinal nucleus and spinal tract of trigeminal nerve. Here we have fasciculus gracilis and fasciculus cuneatus fiber, and we are receiving this fiber from the posterior white column of the spinal cord. They are responsible for the 2-point discrimination, position, and vibration sense. Spinocerebellar tract are again ascending tract, and they give kinesthetic sense. Lateral spinothalamic tract, they carry the pain and temperature sensation from the skin. from the spinal cord to the thalamus. Reticular formation. Reticular formation is an ill-defined meshwork. You will find this reticular formation in the entire length of brainstem. It is a diffuse system of nerve fiber and nerve nuclei that control the consciousness. Now we have pyramids. Pyramids receive corticospinal tract from the cerebral cortex, and 80% of this fiber cross to opposite side while moving backwardly and laterally, and they form lateral corticospinal tract, while 20% fiber ascend downward as it is, and they form the anterior corticospinal tract. So when these fibers cross to the opposite side, they're actually detaching the anterior horn from rest of the central gray matter. So this anterior horn divide to form supraspinal nucleus of first cervical nerve and spinal nucleus of accessory nerve. Now we'll move to the next level, that is at the level of sensory decussation. Here, nucleus gracile and nucleus cuneatus become more prominent. So the fibers from fasciculus gracilis and fasciculus cuneatus end in these nuclei. From here, fibers of second order neurons start, and these are called internal arcuate fiber. They move forwardly and medially, and the fibers from the opposite side decussate at this level and form medial lemniscus. So when the fibers are moving from the dorsal aspect to the ventral aspect, they are actually detaching this spinal nucleus and spinal tract of trigeminal nerve from rest of the central gray matter. Now we have accessory cuneate nucleus. So this nucleus receives the most lateral fibers from the fasciculus cuneatus, and these fibers relay in these nuclei. From here, posterior external arcuate fiber arise, and these fibers carry the proprioceptive information to the same side of cerebellum. Now we have MLF. What are MLF? These are medial longitudinal fasciculus, and they actually connect the third, fourth, sixth, eighth, and spinal root of the 11th cranial nerve, as these nerves are involved directly or indirectly in gazing. In the central gray matter, we have hypoglossal nucleus, dorsal nucleus of vagus, and nucleus of tractor solitarius. Rest of the structure we have studied in the previous section. Now we'll move to the transverse section of medulla at the level of olives. So in the posterior lateral aspect, we have inferior cerebellar peduncle, while in the central portion, we have medial longitudinal fasciculus, tectospinal tract. So tectospinal tract are descending tract, and they are responsible for the head and neck movement in response to auditory and visual reflexes. Now we have medial lemniscus, and here we have the pyramids. So anterior medial to pyramids, we have arcuate nucleus. So what happened during the development, pontine nucleus from the pons drop at this level, and they form the arcuate nucleus. So these nuclei receive fibers from the cerebral cortex, and they send efferent fibers in the form of anterior external arcuate fiber to the opposite side of cerebellum through the inferior cerebellar peduncle. So then we have inferior olivary nucleus. Inferior olivary nucleus is very important as it regulates the signals from the spinal cord to the cerebellum so that motor coordination can be maintained. Then we have these nucleus. So the hypoglossal nucleus, from here, hypoglossal nerve arise, and there we have nucleus ambiguous. From here, motor fiber of 9th, 10th, and 11th cranial nerve arise. So the vagus nerve, which is 10th cranial nerve, receive fibers from the dorsal nucleus of vagus, which form the main bulk of this nerve. It receives fibers from nucleus of tractor solitarius and nucleus ambiguous. All these fibers join to form the vagus nerve. So now we'll move to next part. So here we have blood supply of medulla. So you can see we have two vertebral arteries, and these two vertebral arteries join to form the basilar artery. Vertebral arteries have branches, and these are anterior spinal artery anteriorly and posterior spinal artery posteriorly. We have posterior inferior cerebellar artery and interior inferior cerebellar artery. So the arteries which are surrounding the medulla oblongata, they will going to supply the blood to medulla. So these are two vertebral arteries, anterior and posterior spinal artery, anterior and posterior inferior cerebellar artery, and next we have basilar artery. Now we'll see the clinical anatomy. So The paralysis of the muscle supplied by the last 4 cranial nerve arising from the medulla leads to the bulbar paralysis. Now we'll see the common vascular lesions in the medulla, and these are due to thrombosis of posterior, inferior, cerebellar, and vertebral arteries, which will lead to lateral and medial medullary syndrome respectively. So, in this diagram, we can see that posterior inferior cerebellar arteries supply the dorsolateral aspect of the medulla and inferior surface of the cerebellum. So when thrombosis occur, this area will get affected, and the structures which are involved in this area, they will lose their function. So there will be dizziness due to involvement of vestibular nuclei, which is responsible for maintaining the balance. Then we have ipsilateral ataxia due to inferior cerebellar peduncle, ipsilateral loss of pain and temperature sensation over the face due to involvement of the vestibular nuclei. Then there will be Horner syndrome. Horner syndrome is due to the descending sympathetic tract, as they are the part of reticular formation. Horner syndrome, in Horner syndrome, the size of the pupil decrease and eyelids droop, and the affected side of the face do not sweat. Then, because of nucleus ambiguous involvement, there will be ipsilateral paralysis of muscles of palate, pharynx, and larynx, as nucleus ambiguous supply motor fiber to the 11th accessory nerve, and 11th accessory nerve supply these muscles. Then we have contralateral loss of pain and temperature sensation from the trunks and limb due to involvement of spinothalamic tract. So this was all about lateral medullary syndrome of Wahlberg. So we have studied the sign and symptoms. Now we'll see the medial medullary syndrome, which is Dejerine anterior bulbar syndrome. So what exactly happened? The branches of vertebral arteries supply this paramedian region. So when there is thrombosis in these arteries, this area will get affected, and the structures involved in this area will lose their function. So there will be ipsilateral paralysis and atrophy of half of the tongue due to involvement of hypoglossal nerve, contralateral hemiplegia due to corticospinal tract, and contralateral loss of vibration and position sense due to involvement of medial lemniscus. So this was all about the clinical part of the medulla oblongata. This was all about this session, and thank you for listening me. I'll end. Thank you everyone for listening this carefully.
Join video. Jyoti?
Yes, ma'am.
Yeah, please join video. It was really a nice presentation from you. And as I requested, you kept my request with heart and you finished within time.
Thank you, ma'am.
But you have presented it very well.
Thank you so much, ma'am.
Very much informative and very nice. Yeah.
Actually, one of the main.
I think Rupesh sir will conclude. Yeah.
Yes, ma'am. One of the main topic for presentation, as it is medulla oblongata. So I need to thank Delhi Pharmaceutical Sciences and Research University College principal and vice principal and your guide or your staff firstly. Then I will thank Jyoti for presenting well. So we'll look for further association with us for the presentation. Thank you, and we'll meet in the next session.
You too join with us, and if your appreciations are there in your chat box, thank you. See you.